Hello everybody, this is Dr. Medicine RX and in today's video we'll be learning about Pityriasis rubra pilaris. So breaking down the term, Pityriasis means there's going to be some sort of scaling seen. Rubra, that is the disease, is going to be a bit erythematous or showing reddish or orange discoloration, and pilaris means that the primary pathology will be involving the hair follicle. This disease is also called as Deverge's disease or lichen rubra pilaris. It is a chronic papillosquamous disorder. Coming to etiology, the etiology is largely unknown. Two types of patterns of disease were seen. One is the familial pattern, the other is acquired. The familial pattern was commonly seen in childhood and it was associated with CARD gene, and the pattern of inheritance was autosomal dominant. However, some autosomal recessive patterns of inheritance was also noted. Coming to acquired, various causes have been associated with PRP later in life, like vitamin A deficiency, any preceding infections, exposure to UV radiation, minor traumas, malignancies like that of lung, colon, kidney, larynx, autoimmune diseases such as systemic sclerosis, celiac disease, and also a vast majority of cases have also been seen to be associated with HIV infection. Coming to epidemiology, both males and females are equally affected, and three distinct age groups have been recognized. So first is in the early childhood, that is less than 10 years of age, then the late childhood, that is 11 to 19 years of age, and in adulthood 40 to 60 years of age. So three patterns or three distributions of age groups of PRP in age groups have been identified. Coming to clinical features, so this disease, it classically begins on the head or the scalp and it progresses caudally. So this is the characteristic feature of classical Pityriasis rubra pilaris, that is it begins on the head or the scalp and it progresses caudally. On the scalp, diffuse erythema and fine scaling can be seen. Coming to the changes in the skin, well-defined small follicular acuminate pinkish yellow scaling papules are seen. They are widespread in distribution. So the primary dermatological lesion is going to be a papule. The papule is going to be small, acuminate, pinkish yellow with scaling, and it will be follicular in location. And these papules are widespread. They coalesce to form plaques, and all these plaques, they finally coalesce to form and involve larger body surface areas leading to erythroderma. So the lesions present symmetrically on trunk and limbs, and the scales are brawny, that is brawn-like, and reddish orange erythema is seen. The key finding is follicular hyperkeratosis on an erythematous base. Islands of normal skin within affected areas known as nap sclerae are present. So here in the sketch below, the whiter areas are the uninvolved skin. They have sharply defined margins. These margins are because of the surrounded affected areas which appear orange or reddish, and these unaffected areas with well-defined margins are called as nap sclerae. Hyperkeratotic follicular papules on back and proximal phalanges on fingers may feel like nutmeg grater. Yellowish gross hyperkeratosis of palms and soles is seen, that is palmoplantar keratoderma is seen, and also this hyperkeratosis with painful fissures and orange discoloration is called as a Pityriasis rubra pilaris sandal or the PRP sandal. Pruritus and burning sensation can be present. The nails can be thickened, they can be brittle, dull, rough with splinter hemorrhages. Oral mucosa is rarely involved, and eye shows ectropion, blurred vision and dryness. Prolonged erythema and erythroderma leads to peripheral edema and high output cardiac failure. Coming to the types of Pityriasis rubra pilaris, 6 types have been identified. So adult, juvenile and variable types. 3 broadly they have been divided into adult, juvenile and variable types. So first type is the classic adult type, where all the above symptoms are present. So it is the most common type. Whereas the second type is the atypical adult type, where instead of the brawny scaling, lamellar or ichthyosiform lesions are seen and eczematous changes are present. The third type is the classic juvenile type. So above mentioned features are present, but they present at the age of 1 or 2. Then the fourth type, it is the circumscribed juvenile type. So in this, the lesions are going to be seen prepubertally, and they are going to be similar to psoriasis, and the lesions are localized, whereas rest of the types have generalized distribution, whereas in the fourth type, that is a circumscribed juvenile type, the lesions are going to be localized. Coming to the fifth type, atypical juvenile type, where scleroderma like appearance of hands and feet are seen, and the sixth type is the HIV infection associated type. Coming to infection investigations, the diagnosis is clinical. If you see any hyperkeratotic papules on reddish or orange reddish erythematous background, the first suspect should be Pityriasis rubra pilaris. And coming to the HPA examination, the follicular lesions, they show shoulder parakeratosis, that is on either side of the papule there is going to be parakeratosis. The infundibula are going to be dilated with follicular plugging. There is going to be perifollicular lymphocytic infiltrate and prominent arrector pylorem. Coming to the findings in non-follicular lesions, these findings they resemble psoriasis, that is there is going to be parakeratosis, acanthosis, elongated retinal ridges, dilated blood vessels and all. And along with that, there can be some acantholysis, or there can be sebaceous atrophy, and arrector pylorem can be hypertrophic as well. Coming to dermoscopic changes, round or oval yellowish areas surrounded by dotted vessels can be seen. Coming to the management, basic skincare in the form of topical emollients and mild keratolytics such as 3% salicylic acid and 20% urea are the first line of basic skincare. Next, coming to topicals. Topical steroids can be useful for pruritus, scaling and erythema. Topical calcineurin inhibitors such as tacrolimus and pimecrolimus have been found useful in some cases. Topical calcipotriol has also been found to be useful in certain cases. Even topical retinoids can be used. Coming to the third line, that is systemic drugs. The first line in systemic drugs is oral retinoids. Other drugs that can be given are oral vitamin A, methotrexate, cyclosporin, azathioprine, and others such as cyclophosphamide, biologicals, and extracorporeal photochemotherapy. Now coming to the treatment ladder, first line of choice are going to be the retinoids. So isotretinoin in a dosage of 1 mg per kg, or alitretinoin in a dosage of 30 mg per day, or acitretin in dosage of 25 to 50 mg per day are to be started. If the disease is not controlled, or if any side effects are seen over the next 12 weeks, then second line of drugs such as the immunosuppressive agents, which include methotrexate, azathioprine or cyclosporin, are to be tried. If still the disease remains to be uncontrolled, or if there are any side effects over the next 12 weeks, third line of treatment, that are the biologicals, that is infliximab, adalimumab, ustekinumab, secukinumab and etanercept can be tried. Patients should be regularly monitored for any electrolyte imbalance, or if there is any secondary bacterial infections or hypoalbuminemia or any sepsis. Thank you. Subscribe for more.